My name is Brett Elo, and I practice anesthesia and critical care, and I'll be talking to you about anesthesia for general surgery, and it's basically taking you back to the basics and giving you a comprehensive understanding of what we do in the operating room and how we can work well together. And for disclosures today, I don't have any. And we'll get started off with the types of cases that a surgeon might bring to an anesthesiologist and the things that we think about when we hear that there's a case to be done. So in general, there are three types of cases that we'll categorize, and they'll be either emergent, urgent, or elective. Now, if you come to me with an emergent case, I'm really not going to ask too many questions, but the couple things that I really want to know, first of all, does the patient give consent or does the family give consent for the patient? Second, are there any specific end-of-life wishes? Did the patient have a DNR in place before whatever event occurred? Did they not want to live on a prolonged ventilator? Did they not want to receive blood? Did they not want to be resuscitated in case their heart were to stop or they were to go into respiratory arrest? And some of these things, even though it's an emergent procedure, could affect how I take care of the patient or the things that we'll do in the post-op period. And last, if we do go to the operating room, will they make it off the table and have a chance at a meaningful recovery? So is everything we're doing for them worthwhile? Will we be able to get them to a place that they'll have a meaningful life and be satisfied with that after the surgery? The next type of case is an urgent case. And by urgent, this can mean it needs to go within the next hour, it needs to go in a few minutes, or maybe it can go the next morning, the next day. And so urgent is kind of a broad term. And these are the cases that we really have to think about. Is the patient optimized, or is there something we can do within that time frame that you're giving us to make the patient's odds better in doing well with this procedure? Some of those things that we can do is look at our resources. Is the right surgery team in place? Is the right nursing team in place? Is the right anesthesia team in place? And by that I mean, do we need a specialist? Is it a pediatric case? Is the person on call not comfortable doing pediatric anesthesia? Is it a cardiac case? Is the cardiac anesthesiologist not there that time? Is it at the end of a really bad night and is the entire team exhausted? Do we have the reps here? Do we have all the special equipment that we might need? Do we need extra hands there? Is it a case where we don't think we'll be able to do it by ourselves and it's overnight and maybe we need another anesthesiologist or a nurse anesthetist or an anesthesia assistant to be there to help us with that procedure? Finally, you might come to us with an elective case, and this is when we start talking about really making sure that the patient is optimized. And so you always hear about preoperative clearance, and sometimes this is not so helpful because you'll see a note in the patient's chart saying that the patient is cleared for anesthesia and to avoid hypoxia and hypotension. So obviously we do this for every single patient that we take care of, and so we really need to go a little bit deeper into the patient's medical history to look to see if they're optimized. So on the day of surgery, we take into consideration how the patient's doing in general. So usually I'll ask the patient, how are you feeling today? Is there anything bothering you? Did you have a recent fever, chills, upper respiratory infection, lower respiratory infection, GI distress? Did you have diarrhea? Are you peeing okay? Are you urinating okay? I want to know if anything's changed today versus any other normal day, and I want to make sure that that patient is tuned up as much as possible today for this procedure. Then I'll get into specific organ systems. So I start head to toe, and when I ask them about their neurological system, I want to know if they've had a recent stroke. Have we given enough time for that stroke to recover before doing an elective procedure? Do they have a history of seizures? Have they had any recent seizures? Are they taking their seizure medications as prescribed? Or is their mental status altered? Is a family member there that's telling us that they're just not themselves? Is something different today? Is the patient going through alcohol withdrawal? Is the patient have decompensated kidney failure or liver failure that's causing them altered mental status. So these are the things that I would want to know for an elective procedure. Next, I go into their cardiac condition. Do they have decompensated heart failure? Are they obviously short of breath at the bedside? Are they having intermittent chest pain? Do they have a new arrhythmia? Do they have an old arrhythmia that's uncontrolled, like atrial fibrillation with rapid ventricular rate? And last, are they waiting on any tests that either are not completed yet or they have not done yet that a cardiologist recommended prior to procedure? And this sometimes puts us in a difficult situation or position, but if there's a note on the chart from a cardiologist saying that they want to see a stress test before we do an elective procedure and the patient has not had that yet, then sometimes we can think of it as being a liability as going forward with a procedure, in case the patient would have any issue during the stress test, like cardiac ischemia and require a stent. If we had gone ahead with an elective case without these results, sometimes we would be liable for that patient's outcome because we would have ignored the cardiologist's recommendation. This is an algorithm in preoperative cardiac testing, and it's a busy slide, but I tried to circle out and enlarge the part that I thought was important here. And if you can see, in a patient that does have some cardiac risk factors or a higher surgical risk, you can see that there's one important factor, and is that patient able to perform what we say 4 metabolic equivalents, or 4 METs. And what 4 METs is basically walking up a flight of steps without getting short of breath. And as you can see on the right side, if a patient can in fact do that, then we have pretty good evidence that there's no further testing required and that we can proceed for a surgery. And again, this is talking about elective surgery. Obviously, if the procedure is emergent, we would go ahead and do that procedure and provide anesthesia for a patient and deal with whatever types of risk factors or ongoing clinical events were going on at that time. When we go into the pulmonary system, we think about the patient's risk for prolonged intubation. Do they have significant pulmonary disease where if they were able to take different medications or given time to recover from whatever condition they have, that they would do better with a general anesthetic than today? And that includes asthma or COPD medications. That includes upper or lower respiratory infections like recovering from pneumonia or bronchitis. And I put a little mention there about pulmonary function tests. And this is something that as anesthesiologists, we typically don't need because it really doesn't change what we'll do for the procedure and the outcome. So if a patient has poor pulmonary function tests and they're optimized, we are still going to go ahead and intubate the patient and allow the surgeon to do the procedure, and then we'll take care of whatever we need to at the end of the case, whether that be a prolonged intubation or an extubation. But just having the pulmonary function test doesn't change our likelihood of extubating the patient at the end of the procedure. It's still a clinical decision for us. When we look at the GI system, we want to know if the patient's nauseous. That'll make them an aspiration risk if they're vomiting. It also will tell us about their volume status. We want to know if they have liver failure and if they're decompensated, how they'll react to our medications that are metabolized by the hepatic system. And then does the patient have a nasogastric tube or an orogastric tube? And sometimes if a patient's obstructed or is at risk for aspiration, sometimes we'll actually go ahead and place this preoperatively so that we can reduce the risk of aspiration when we go ahead for induction. When we look at their GU system, I want to know if the patient's making urine, if they've had recent labs, and if their creatinine is normal or is it elevated, and if it's elevated, is it getting worse? If a patient is not making urine, is having worse kidney function, and we go ahead with an elective procedure, they're obviously at risk for fluid overload and respiratory complications from that. Also, with their urine output and their creatinine levels, I want to know what their potassium is. And having a high potassium is a potential for canceling a case. And I can't give you a specific number because it does change from provider to provider and patient to patient. Someone that maybe runs a little high and is a chronic kidney patient and typically has a high potassium, it might be safe to give a general anesthetic to that patient with an elevated potassium versus someone that has never had any kidney injury or chronic kidney disease that presents with an elevated potassium. We go on to the hematologic system, and we'll look at anemia, and many of our patients do come in with anemia of chronic disease or anemia that's explained, but if a patient presents on day of surgery with a low hemoglobin that's unexplained, it might be something to take a look at. The same with thrombocytopenia. It helps us understand if we'll need to order platelets or other blood products prior to the procedure, and it also will change if we're providing a neuraxial technique and the risk of bleeding or epidural hematoma. Is the patient coagulopathic? And again, do we need to order blood products to try to reverse their coagulopathy? And finally, does the patient have antibodies? And if we're anticipating the need for blood products and a patient has significant antibodies that could take hours to even days to receive blood from the Red Cross, are we okay proceeding with this elective procedure in the event that we will not be able to get blood in a sufficient time? When we look at their metabolic system, we want to know if they have diabetes and is it controlled, and if it's uncontrolled, how high is their blood sugar and what complications do they have from that elevated blood sugar, which would mean is the patient in diabetic ketoacidosis? Are they hypovolemic or dry from their hyperglycemia and excessive urination? Are we at risk at putting that patient into diabetic ketoacidosis from the stress of the procedure that's about to happen? Also, you may hear about cases being canceled for severe hyponatremia with mental status changes and hypokalemia that could put a patient at risk for different cardiac arrhythmias. Next, we'll talk about NPO status of a patient. And on the next slide, I have a list from the ASA with our pre-procedure fasting guidelines. And typically, historically, what we've told patients is nothing by mouth after midnight. And that's because when you tell a patient that they can have something on the day of surgery, they typically don't follow directions. When in fact, patients are actually allowed to have clear liquids up until 2 hours before their planned procedure. And if you can see in the red box, we have clear liquids listed as water, fruit juices without pulp, carbonated beverages, clear tea, and black coffee. So many of our patients can't go without their morning coffee. And if we tell them they're allowed to have coffee 2 hours prior to the procedure, many times we'll find that the patient actually did have some cream in their coffee, and then we're stuck in a predicament and having to cancel the case. So it's not unreasonable to tell a patient nothing by mouth after midnight, but in fact, these are the actual recommendations. It's 2 hours for clear liquids. And you see a light meal is 6 hours. That typically consists of toast and clear liquids or similar. If they've had any fried or fatty foods, that goes to 8 hours. And for an elective procedure, we would be at risk if a patient aspirated and we did the case before 8 hours. Next, we're going to go on to talk about the anesthetic plan and some of the things that we think about in our heads prior to going through with an anesthetic. So you'll see here type of anesthetic, choice of airway, choice of lines, access, and monitors, the process of induction, and the maintenance drugs we'll use for anesthesia, our choice in amounts of fluid and blood products, what we'll do for pain control, and at the end of the case, how we'll decide on extubation and the patient's disposition afterwards. Starting with the type of anesthetic, from the most basic to the most involved is minimal sedation or anxiolysis, and this typically doesn't involve an anesthesia team. It's giving some gentle medications to provide some anxiolysis for patients that are undergoing very simple procedures. Next will be the moderate sedation, which is also known as conscious sedation, and it's similar to anxiolysis, but the medications might be a little bit more sedating and include different classes of medications. And again, typically, this is not something that an anesthesiologist or an anesthesia team is involved with. But as we go on to the next level, which is deep sedation, or what we call monitored anesthesia care, or MAC, this will involve an anesthesia team, and you'll see on the next page what this involves. And finally, general anesthetic obviously involves an anesthesia team, and this is the most complex and invasive type of anesthesia that we can offer. And with all of these types of anesthesia, we can perform something called a regional or a neuraxial block, and they can be used for the actual procedure itself or for postoperative pain afterwards, and again, we'll talk about that later. This is a chart from the ASA describing the different types of anesthesia and the different interventions that we may need to partake in a patient undergoing this type of anesthesia. And if we focus on the right two columns, the MAC or deep sedation and the general anesthesia, and these are the things that we'll typically provide. If you can see under responsiveness in a MAC, a patient should be responsive to repeated painful stimuli, whereas in a general anesthetic, the patient is typically should be unarousable even with the most painful stimulus provided. And looking at the airway, in a case that's under MAC, an intervention may be required for the airway, but typically the patient is breathing on their own. Whereas with a general anesthetic, the airway frequently requires, or almost always requires, intervention. In a patient that's undergoing a MAC anesthesia, their spontaneous ventilation is typically adequate. We usually don't have to intervene again, and if we do, it's a chin lift maneuver or a jaw thrust. But with a general anesthetic, they're usually not spontaneous ventilating. Now, when we talk about a MAC, I have in quotations just the MAC because many people do think that a monitored anesthesia care is a simpler form of anesthesia than general. But if you look at some papers, and this one's from Anesthesiology in 2006, and you look at the percentage of claims in an anesthesia group from the time period before then, if you look at patients that suffered from death or permanent brain damage due to an anesthetic, you see that the largest proportion of patients in this category were undergoing a MAC anesthetic. So it's not just a simple MAC. It's not an easy anesthetic. We don't have an airway. We're typically in an off-site room without a lot of help, without a lot of equipment. And it's just something to be aware that a MAC isn't always easier than a general anesthetic. Again, to describe the MAC anesthetic, we typically use this for shorter procedures with minimal painful stimuli. Obviously, for open procedures or complex procedures, a patient will not tolerate a deep sedation, and they'll more frequently require a general anesthetic. With a monitored anesthesia care anesthetic, the surgeon should be okay if the patient does move. We can't guarantee that the patient's paralyzed. We can't guarantee that the patient will not respond. And if the patient moves, the surgeon will stop what they're doing, will provide additional medication, wait until the patient's comfortable, and then go ahead with the procedure. Sometimes we'll use a MAC when the patients are too sick to really tolerate a general anesthesia. And this takes some careful coordination with the surgical team. But if a patient, for whatever reason, whether it be pulmonary or cardiac, is told that they shouldn't have a general anesthetic or is too sick for a general anesthetic, we can work with the surgeon, provide a deep sedation and some local anesthetic, or maybe even a neuraxial or a regional block, and the patient would tolerate the monitored anesthesia care. Again, with the airway, intervention may be required, but it's typically not. And when that intervention is required, it's usually a simple chin lift or jaw thrust to move the soft tissues out of the way of the airway and relieve some obstruction. Some of the medications that we use for monitored anesthesia care include opioids, which for the anesthesia team is typically fentanyl, benzodiazepines, which typically is midazolam, And we can use small doses together to make the patient comfortable. And on top of that, we typically use a propofol infusion. It's usually not a general anesthetic dose, but enough to keep the patient comfortable. If we need to add additional medications, ketamine is always something that is in our back pocket that provides a good dissociative state, so the patient is more comfortable, doesn't remember, and isn't aware of the actual procedure. And finally, I have listed dexmedetomidine. It's a little bit more difficult to use dexmedetomidine for a MAC, but it is a very, very good drug to keep a patient spontaneously breathing. So if we have a patient that has significant respiratory disease and they need a deep anesthetic, dexmedetomidine is a good drug to put the patient in a comfortable state and at the same time ensure that they're adequately ventilating and oxygenated. Next, we're going to go on to talk about general anesthesia, and this is obviously the hallmark of our practice. So when do we use general anesthesia? Obviously, when there's high surgical or painful stimulus. Also, if it's a small procedure, but the patient is an aspiration risk or needs airway protection, and we'll talk about that later on, but if they can't tolerate a MAC because we're worried about the patient vomiting and aspirating, then we'll lean towards a general anesthetic. If the surgeon needs paralysis for whatever reason, the patient will obviously have a general anesthetic because we will paralyze their respiratory muscles. If the procedure is planned to take a long period of time, it will be more difficult for us to keep a patient comfortable with a deep sedation and protect their airway, so we will err on the side of caution for a longer procedure and use a general anesthetic. If the patient is unstable or very sick, and we think that during the procedure they'll have swings in their cardio or respiratory function, then a general anesthetic is preferred so that we can better control both their breathing and their cardiovascular status with whatever medications and interventions that we have. Now, with the general anesthetic, there are different types of airways that we do use. And I want to mention that just because a patient doesn't have a breathing tube or a supraglottic airway does not mean that they're not under general anesthetic. So if you can remember a few slides back, really the hallmark of general anesthesia is that a patient does not respond at all to a painful stimuli. And sometimes we do what looks like a MAC or a deep sedation to the surgeons, but it's actually a general anesthetic with the patient breathing spontaneously with a good open airway and a nasal cannula or a mask. So just because they don't have an endotracheal tube or a supraglottic airway doesn't mean they're not under general anesthesia. I'd like to mention that we typically call a supraglottic airway an LMA, but an LMA is actually a brand name of a laryngeal mask airway. And so the proper term really is supraglottic airway, but many people do call that an LMA. So when we talk about the choice between using an endotracheal tube or versus a supraglottic airway, there are a few things that come into play. The major thing is that an endotracheal tube is a protected airway with a balloon cuff in the trachea to prevent any aspiration and to provide positive pressure ventilation. Whereas a supraglottic airway or an LMA is not actually a protected airway. It sits above the vocal cord, so if a patient were to have some emesis, they could potentially aspirate. Anytime there's a laparoscopic procedure, we will use an endotracheal tube, and that's because the abdomen is filled with pressure and the diaphragm gets pushed up into the thorax, and it is difficult for a patient to breathe well with an LMA. If a patient is obese and it's a long procedure, and again, we don't think that they'll be able to tolerate laying supine with the weight of their chest on their thorax, we will err on the side of caution and use an endotracheal tube. And the same thing for steep Trendelenburg. It's not a position that facilitates spontaneous breathing, so an endotracheal tube is preferable. Now going over to the supraglottic airway, we typically don't use paralytics with the supraglottic airway. It's not contraindicated, but it's usually a case where a patient is breathing spontaneously. There is less irritation when a supraglottic airway is used. The supraglottic airway does not go through the vocal cords, so it doesn't irritate the vocal cords and it doesn't irritate the trachea. So if you have someone that could be irritable, like a smoker or someone with an upper respiratory tract infection, they may actually do better with a supraglottic airway and less stimulation to their respiratory tract. This is something that we might use on someone like an opera singer, where if we used an endotracheal tube, we could potentially rub up against the vocal cords and cause, whether it's very minor damage or changes to their vocal cord anatomy, it's something in an opera singer that we wouldn't actually want to do. And if you've seen an LMA or a supraglottic airway used before, sometimes the emergence and extubation is quicker and easier because the patient is breathing spontaneously, and simply when the case is over and the patient awakens from anesthesia, we really can just pull out the supraglottic airway and bring the patient off to the recovery room. I want to add a slide here about our difficult airway algorithm in anesthesia. And I mentioned on the left side here the difference between cannot intubate versus cannot ventilate. They're really two different situations. Ventilation basically means that we can exchange air and eliminate CO2 from the patient, and that typically means we're oxygenating as well. Cannot intubate means that we can't get a breathing tube through the cords, but many times you can actually ventilate the patient in other ways, even though you can't intubate, and that's a much easier situation. We'll talk about that through this algorithm. So on the top right, you'll see that we've induced general anesthesia, and your initial attempts in the red box, initial attempts at intubation are unsuccessful. At this point, we're assuming that you can still ventilate, and so we actually have plenty of time to try other techniques, to call for help, to use video laryngoscopes, to use fiber optic bronchoscopes. But as long as we're ventilating the patient, and again, most likely oxygenating the patient, this is really not an emergency. But if you go down one level in the red box, this is where a face mask ventilation becomes inadequate. And this is when we really can get ourselves into trouble. So you see the acronym SGA, which stands for supraglottic airway. And this is where the LMA or the supraglottic airway really comes in to help and can be life-saving. And so that was typically our first choice if we can't intubate and then we also can't mask ventilate. And so we'll try a supraglottic airway, and many times the supraglottic airway will work and will buy us some more time to either wake the patient up or try a different technique to intubate, whether that would be through the LMA itself or another piece of equipment or a different set of hands that may be more experienced than the person that initially tried. But in the red box, the third red box on the right, when a supraglottic airway is not adequate or not feasible at the time, is when we move into our emergency pathway, and that's when we ask the help of our surgeons. And as you can see, our emergency emergency invasive airway access comes into play, which could be an emergency tracheotomy or cricothyroidotomy, but any way we can to be able to ventilate and oxygenate that patient. Next, we're going to talk about patient monitoring. And in the simplest form of patient monitoring is our standard ASA monitoring, which is really 4 or 5 monitors for any patient that's coming to the operating room. The first type of monitoring is oxygenation. And again, in its simplest form, this is a pulse oximeter on a finger or an ear. And if the patient does have a secured airway, we can measure inspired and expired FiO2 or oxygen concentration. The next thing we measure is ventilation, and that could be visual by chest rise, but with the more advanced monitors that we have, we typically do follow the end tidal CO2, and that can be with a nasal cannula, that can be with a face mask, and obviously with a secured airway or a supraglottic airway. The third thing is circulation, and that's measured with blood pressure. In simple forms, it's a non-invasive blood pressure cuff, all the way up to invasive blood pressure monitoring, and either 3 or 5 lead telemetry. And typically the 5 lead will include on the monitor lead 2 and lead V5 or 6. And that's because lead 2 will help us monitor the patient's rhythm, so it allows us to see a P wave and determine if the patient is in sinus rhythm. And then V5 or 6 helps us to determine ischemia in the left ventricle. So whether it's ST changes or ST elevations or T wave inversions, it's our best lead for the left side of the heart. And finally, we do measure temperature, and that's for any increases in temperature and risk for malignant hyperthermia, or decreases in patient temperature and risk for coagulopathy. So one of our monitors that we may place for a patient is an arterial line. And this is obviously an invasive line, but we do use it frequently, and there are a few indications for an arterial line. The first one being more vigilant blood pressure monitoring than just a blood pressure cuff every 3 to 5 minutes. Patients that would need more vigilant blood pressure monitoring would be those with an aneurysm. So if the patient got very hypertensive and we weren't aware of it, we could have a ruptured aneurysm. And the same thing goes for severe hypotension or swing in blood pressure, an aneurysm could rupture. Also patients with cardiac disease, to the point if they are very hypotensive and we're not aware of it, they could have myocardial ischemia. So we would want to place an arterial line to monitor their blood pressure a little bit closer. Also, if we need frequent blood draws, let's say the patient was at risk of bleeding and we needed frequent hemoglobin and hematocrit levels, or if a patient was in any kind of respiratory distress and we needed to measure their blood gas for PaO2, or if we needed to check their glucose on an insulin infusion or an ACT for vascular or cardiac cases. We will have to decide whether we want to place this arterial line pre-induction or post-induction. So typically, if the patient does need that vigilant blood pressure monitoring, like we talked about, or if they come in some kind of distress or shock or septic shock, we would think about putting an arterial line in this patient before we induce, so that we can really monitor the patient's hemodynamics on induction. And if they just simply needed blood draws throughout the procedure, then it's fine to go to sleep and put the arterial line after induction. Our first option is usually a radial arterial line, and that's because the hand has collateral circulation with the ulnar artery. But if we can't get a radial for whatever reason, it's really a question where we go next, and whether that be femoral or axillary or brachial. And the question mark after the brachial is because it doesn't have collateral circulation, and it is a risk to have a thrombus in the brachial artery and end up with a cold hand afterwards. So we really should be careful about placing brachial arterial lines. Also, one of the new monitors that we're seeing are minimally invasive cardiac monitoring, and they have some algorithms that read the area under the curve of the arterial line, and so they can actually tell us a patient's cardiac output and index and systemic vascular resistance just based off of the arterial line waveform. Next, we may need a central line for monitoring purposes, and we'll talk about this later, a central line as access, but for monitoring purposes, if we're doing a hepatobiliary case or a liver procedure and the surgeon asks us to keep the central venous pressure down to avoid congestion, a central line might help us in that matter. And if the patient's going to have significant blood shifts, or for whatever reason we can't get an arterial line and we need to take blood samples during the procedure, a central line will help us there. Some more invasive monitors might be a pulmonary artery or Swan-Ganz catheter, and it's starting to fall out of favor when we're starting to use transesophageal echo a bit more, and they may be able to do the same thing for us, but just through different ways. Some of the reasons we might want a pulmonary artery catheter is if the patient has severe pulmonary hypertension and we need to monitor pressures, or they have some right ventricular dysfunction or failure, and a PA catheter will help us monitor the right side of the patient's heart. Also, again, if they're having massive fluid shifts, massive loss of blood, it may help us to monitor their filling pressures. And then again, the transesophageal echo can help us the same way. We can look at the patient's left ventricle, right ventricle, determine if the patient is under-resuscitated or hypovolemic. We can also look at their valvular function, specifically if they have systolic anterior motion, or what we call SAM, which is when the mitral valve may actually obstruct the aortic outflow tract. And so we can make changes to the patient's hemodynamics and prevent SAM while the case is happening. But really, the determination whether to put a PA catheter versus just using a transesophageal echo is determined on what you need in the post-op monitoring. If it's just intraoperative monitoring, either of these will work fine. But we can't actually leave the transesophageal echo probe in the patient to go to the ICU. So if the ICU team were to want some invasive monitoring, they would prefer that we place a PA catheter in the operating room so that the patient can be watched in the ICU and their hemodynamics could be monitored. Another monitor you might see is called a BIS monitor, and that stands for bispectral index. And that helps us monitor depths of anesthesia or awareness. And how this works is by looking at the patient's EEG, and with a proprietary algorithm, the BIS monitor gives you a score of 0 to 100, with 100 being wide awake and 0 being completely unaware. And we typically target a number of about 40 to 60 for an appropriate depth of anesthesia. And where this monitor really helps us is obviously if the patient has had awareness in the past, we can keep the BIS score low to reduce our risk of awareness again. And if the patient is fairly sick, which usually means they are hypotensive with a normal dose of anesthetic, we can follow the BIS level and decrease the anesthetic and decrease the patient's hypotension by using the BIS monitor target 40 to 60 to bring them into a good range of anesthesia and also less of an anesthetic to make them hypotensive. Moving on to lines and access. Some of the things that we think about before we decide what lines to place, and we may ask the surgeon this, but we want to know how much blood loss to be expected. Obviously, if the case is simple and there's minimal blood loss, then one IV usually works just fine. But if the surgeon comes up to us and tells us that they're very close to major vasculature, or the tumor is highly vascular, or to expect quite a bit of blood loss, then we'll be thinking about putting in extra lines. Also, if the patient is expected to be unstable at all and will need infusions of pressors, or if we're infusing our anesthetic or different opioids, we may want a more secure IV than the one the patient comes with. Whether that just be a second or third IV or a central line, we may need extra access. And again, if the patient's arms are tucked and we won't have access to them throughout the procedure, we might err on the side of caution, and at the beginning of the procedure, before their arms are tucked, we may place additional IV access. So our hallmark line is a central line. And again, some of the reasons why we would place this, maybe the patient has difficult access and we can't get a standard IV on the patient, so we may go straight for a central line. If we anticipate that the patient will need high doses of pressors, we don't like pressors to infiltrate in peripheral IVs, so we'll typically secure a central line in order to give pressors. And again, if we need to give high volume, like blood products, we may choose a central line that can run faster, and that is a MAC, which is a multi-access catheter, or an introducer. And on the right, you see our formula for flow, which is directly proportional to the radius to the fourth. So the higher the radius, the faster the flow, and inversely proportional to the length of the tubing, which is why we like short catheters. The longer the tubing, the slower the flow. And we'll look at these different types of central lines on the next slide here. You can see the PICC line on the left is very long, and so it's fine for giving pressors, it's fine for securing access, but if we have to give large volume of fluid or blood products through a PICC line, we're not typically happy. On the other end of the spectrum is a large bore short central line like the MAC or multi-axis catheter, which does allow us to give fluid and blood products at a very high rate. And in the middle we have different multi-lumen catheters like a triple lumen catheter or a double lumen catheter or even a quad lumen catheter, which typically are a mix between 14 gauge, 16 gauge, and 18 gauge catheters that are longer than a MAC catheter but shorter than a PICC, so could be used for both pressors and a volume line. So moving on to either an adjuvant to a general anesthetic or an anesthetic itself, we'll talk about neuraxial and regional blocks. So when we look at different blocks, we talk about whether we're going to use those for the sole anesthetic technique, and we call that a surgical block, or are we using the block for post-op pain control? And actually we can do both of these, use it for the surgery and use it for post-op pain control, and we'll talk about those. When we talk about neuraxial blocks, we are talking about spinal anesthetics and epidural anesthetics. With the spinal anesthetics, we almost always find the subarachnoid space with a spinal needle. When we're in the CSF, we give a single shot of local anesthetic, and for about 3 to 4 hours, sometimes more with different local anesthetics, we can give the surgeon up to a T4 level of surgical anesthesia, which obviously makes a patient comfortable, and we provide additional sedation to the patient through the IV so that the patient can be in a twilight state or be comfortable and not anxious. And this allows us to avoid the airway. Patient is spontaneously breathing. They're not typically at risk for pulmonary complications afterwards. And it's a simple anesthetic for ortho procedures, sometimes urological procedures or gynecological procedures that in cases that we try to avoid the airway. Just to know that because the sympathetic chain runs lateral to the spinal cord in the thoracolumbar area, we almost always see a sympathectomy, which presents as hypotension and sometimes bradycardia, and we typically use fluids and pressors to alleviate these symptoms, and they're short-lived. With an epidural anesthetic or technique, it differs from a spinal anesthetic because we just come short of the dura, and we end up in the epidural space with almost always we place a catheter, which allows us to give intermittent boluses or continuous infusion of local anesthetic into the epidural space, and again, cover either thoracic or lumbar dermatomes. If the patient has an epidural catheter in place and the procedure is taking longer than expected, we can always give more medication through that catheter and allow the surgeon longer to perform the procedure. Again, this avoids the airway. We give sedation on the side for comfort, and again, we see a sympathectomy with this. And most importantly, with an epidural, it can stay in the patient after the procedure, and we run anesthetic at a lower dose, and it can be used for post-op pain control. Next is a peripheral nerve block, and these are, again, can be used as surgical blocks, so a single shot, or for post-op pain control, which is a catheter left in that space. Upper extremity, we may do a brachial plexus block, which includes an interscalene or a supraclavicular block, which gives anesthetic to potentially the shoulder or the upper arm. And typically we will see a phrenic nerve block, so the elevation of the hemidiaphragm on that side, which could be an issue for patients with pulmonary disease. If that's the case, we go further down the brachial plexus to either an infraclavicular block or an axillary block, which provides anesthesia more distally down the arm and the hand. But again, great blocks for either for surgical anesthesia or post-op pain control. And also with the lower extremity, we can work our way anywhere down the femoral or sciatic nerve distributions, or both at the same time to provide a surgical block or post-op pain control in the lower extremity. Moving on to general anesthesia, we really have three phases of general anesthesia, and that's induction, maintenance, and emergence. When we talk about induction, we're really rendering the patient unconscious. That's really it. It doesn't mean that the patient's paralyzed, it just means that they're unconscious. And when we talk about induction drugs, in the sequence, what you'll typically see us do is give a benzodiazepine, so midazolam for anxiolysis, followed by an opioid, usually fentanyl, for blunting of the sympathetic response to intubation. We'll give lidocaine, which does two things. First, it numbs the IV or the vein that we're about to give propofol in, which usually does sting quite a bit. And it also could blunt the sympathetic response to intubation. Next, we give our induction agent, which we'll talk about. Plus or minus a paralytic agent if we are intubating and need a paralyzed patient for that. The induction agents that you'll see almost always is propofol, and it's a great induction agent for almost all patients, except those that can't tolerate the decrease in cardiac output and systemic vascular resistance that you see with propofol. And those patients are patients that have significant cardiac disease, that are in septic shock, that are hypotensive, that are bleeding, that are hypovolemic, and wouldn't tolerate that change, which is when we would move on to other induction agents such as etomidate, which does maintain fairly stable hemodynamics, ketamine, which when given can increase the sympathetic tone. And in cardiac inductions, classically we've used very high dose fentanyl, which does render the patient unconscious and maintains very stable hemodynamics. And last, for an induction agent, we not often, but do use inhaled volatile agents. For example, in pediatrics or adults when we don't have an IV, or if we're trying to maintain spontaneous ventilation in patients that might have a mediastinal mass or an upper airway obstruction like epiglottitis, and we don't want to risk blunting their spontaneous ventilation. The next thing we'll give is a paralyzing agent. We have two major classes, and those are depolarizing agents like succinylcholine, which we know has a quick onset and quick elimination time, and historically been used to get the patient paralyzed quickly and get a tube in quickly, like in a rapid sequence induction and intubation. And also we have non-depolarizing agents, the most common being rocuronium, but these typically have a slower onset and slower elimination time, and haven't been able to have been reversed very quickly. But now we do have Sugamenex in the United States, and that has really changed a little bit of our practice with paralytics. So in the past, when succinylcholine was the only choice for maybe a difficult airway where we wanted the paralytic to wear off in case we weren't able to secure the airway. Now we can use a large dose of rocuronium to paralyze the patient quickly, and if we were not able to intubate, we can reverse that rocuronium or vecuronium with Sugamenex almost instantly. In induction, there are two types, and it's really a standard versus a rapid sequence induction, and we'll talk about both. With a standard induction, the steps that we take, first we pre-oxygenate the patient before we give any medications, and then we go ahead and induce and paralyze our patient with the medications that we previously talked about. And then we will mask the patient for about 1 to 2 minutes for that paralytic to take effect. And after we think the patient's sufficiently relaxed and paralyzed, we'll go ahead and intubate. Now this differs from a rapid sequence. The reasons we would use a rapid sequence induction is when a patient is at risk for aspiration. So that's really anyone that we say has a full stomach. So do they eat prior to coming in for their urgent or emergent procedure, so inadequate MPO time? Or do they have a bowel obstruction or similar pathology that will cause slow transit time? Do they have gastroparesis or severe GERD to where they frequently vomit or have emesis? We will choose a rapid sequence to prevent aspiration. And so when we do a rapid sequence induction, we pre-oxygenate and we induce and paralyze right away. And as you can see, we don't mask. We hold cricoid pressure as soon as the patient starts to get sleepy and becomes unconscious. And then as soon as the paralytic kicks in, we go ahead and intubate. And it's that masking that really can put us at risk for aspiration. The 1 to 2 minutes of the patient's soft tissues being paralyzed and us potentially putting air into their GI tract and causing emesis and aspiration. The cricoid pressure is also known as the Selleck maneuver. And what it really is 20 to 40 newtons pushed on the cricoid cartilage, which is a complete ring. And that complete ring pushes posteriorly on the esophagus and helps to prevent any type of gastric contents from coming up and into the oropharynx. Do know that this is actually controversial procedure. Sometimes we say it helps and sometimes we say it hurts. Obviously, when it helps, it prevents aspiration. But when it hurts, it can obstruct our view of the airway and actually make it more difficult and make it for a longer attempt at intubation, which is really not what we want to happen. We want to be able to get that tube in as fast as possible. So when we ask for cricoid pressure, if it is obstructing our view, we may ask to take it off so that we can get a better view of the cords and go ahead and secure that airway and prevent aspiration. Once the tube is secure and our induction is over, we move on to the maintenance phase of anesthesia. And almost always we're talking about a mixed anesthetic at this point, which combines a volatile agent, maybe some inhaled nitrous oxide, the volatile agent being typically sevoflurane or isoflurane, the benzodiazepine that the patient may have gotten preoperatively, opioids that the patient may have gotten on induction and intermittently throughout the procedure, either as a bolus or an infusion. And sometimes we do bolus ketamine or provide an infusion of ketamine to try to help with pain control afterwards. If it's not a mixed anesthetic, sometimes we use something called a total IV anesthetic or TIVA. And the reasons to use a TIVA, which is typically a propofol infusion, is if the patient has a risk for malignant hyperthermia, which would be caused by the volatile agent. And sometimes we use a TIVA in a patient that may be at high risk for post-op nausea and vomiting. And so a propofol infusion significantly reduces the risk of nausea and vomiting afterwards. I want to make a point about fluids and how and why we are classically taught and how we give fluids through a procedure. So I want to give the example of an open abdominal procedure. And let's say the case is set to start at 8 a.m. The patient's 70 kilograms. Using the 4-2-1 rule for maintenance fluids, we're talking about 110 cc's per hour of maintenance fluids. So if a patient's been MPO since 10 p.m. the night before, we're talking about already a deficit of 1.1 liters. And we'll assume that the patient also had a bowel prep. And so we've actually induced hypovolemia even more. So we'll give that about half a liter deficit. So our total deficit will be 1.6 liters. And on the next page is a chart that we teach residents and students to write out when they're starting off their careers. And it basically gives us an idea of how much fluid we should be giving the patient hour per hour throughout the length of the case. So here you see a 5-hour case. The first line across is the maintenance fluids, which doesn't change. It's 110 cc's an hour. The next line across is replacing the patient's fluid deficit, which was 1.6 liters. And we typically do that half of the deficit in the first hour and a quarter in the second and third hours. And then on the third line is blood loss. So let's assume the patient lost 100 cc's in the first hour. Anytime we have blood loss, we can replace that with crystalloids at a 3-to-1 ratio. So in the second hour, we're giving 300 cc's of fluid to replace that 100 cc's of blood loss. And you can see in red, the second hour, there's 150 cc blood loss, and in the third hour, 100 cc blood loss for a total EBL of 350 cc's. And you can see how many cc's of fluid we'll have to give to replace. The patient's urine output of 50 cc's an hour. And then something that might be a little bit controversial is third spacing or evaporative losses, but we do know that if a patient has an open belly with lights, the evaporative losses could be anywhere from 6 to 8 cc's per kilo per hour. And here we've used 500 cc's per hour to demonstrate that. So on the bottom line, in the first hour, we need to replace almost 1.5 liters. And across the bottom there, you can see what we would expect to replace for a total of over 5 liters in a 5-hour case, which sounds like a lot, but our rationale is here. And again, this may not happen in every case. We might not actually do this in practice, but this is the classic teaching. Now, in the past years, and this is from 2018, there's been some significant research in restrictive versus liberal fluid management for abdominal surgery. I've included a few papers here, this one from the New England Journal of Medicine, and you can see underlined in green that a restricted fluid regimen was not associated with a higher rate of disability-free survival than a liberal fluid regimen, and was associated with a higher rate of acute kidney injury. So, here it's basically saying that we should be a little bit more liberal with our fluids. And another paper from JAMA, conservative versus restrictive individualized goal-directed fluid replacement in abdominal surgery, and again in green underline. Excessive fluid restriction increased the level of hypovolemia and increased the incidence of post-operative complications. So excessive fluid restriction should be applied cautiously in surgical patients. So if you ask me, on our anesthesia side, I like to be a little bit liberal with our fluids to maintain urine output, to maintain a euvolemia, to avoid the use of pressors, and to keep the patient sufficiently hydrated. Going on to some complications that we see with anesthesia. The obvious one is hypotension. It's a side effect of nearly all of our anesthetics, whether they be intravenous or inhaled. And also with the addition of positive pressure ventilation with decreased cardiac output in a patient that could be hypovolemic, we are almost always seeing patients being hypotensive in just routine anesthetics. But other reasons to be hypotensive, obviously bleeding, severe hypovolemia, a septic response or a systemic inflammatory response, and then if a patient might have any cardiac dysfunction. So when we talk about hypotension, we're obviously going to be using pressors to alleviate the hypotension and maintain adequate perfusion pressure. And again, we almost always, in all of our anesthetics, have some degree of anesthesia-induced hypotension. So it's fairly routine for us to give at least small boluses of phenylephrine or neosynephrine during a general anesthetic. Even a low-dose infusion throughout the case is really nothing for the surgeon to worry about, and we may not even alert the surgeon to this because it is so routine. Even our next drug, our second line for hypotension, which is ephedrine, is fairly commonly used to treat an anesthesia-induced hypotension, we'll call it. So to us, that really is common and nothing that we get overly excited about. If we have to move on to something like norepinephrine or Levophed, then we will typically alert the surgeon, and it's something that we may want to find the reason or the cause of the hypotension, whether it be bleeding, septic shock, vasodilatory shock, severe hypovolemia. But when a patient's on a norepinephrine infusion, this is not the typical anesthesia-induced hypotension. Going on to our second line for septic or vasodilatory shock, vasopressin. Again, if we're on both a norepinephrine and a vasopressin infusion, then the patient is in obvious distress and we're missing something or we're not catching something. The last thing I have listed is an epinephrine infusion or an epi infusion. We'll typically lean on epinephrine in the case of cardiac dysfunction. So if we know if a patient has a very low ejection fraction, myocardial dysfunction, if we have an echo probe in place and we see that there are significant wall motion abnormalities or a very low ejection fraction, then a low dose epinephrine infusion might be indicated to try to help with cardiac output and cardiac index. The next complication that is seen is hypoxia. And hypoxia can happen for different reasons. Obviously, if we don't have an endotracheal tube, the reasons are much different than if we do have an endotracheal tube in place. So if the patient's just breathing spontaneously with a nasal cannula or even a supraglottic airway, we worry if there's an obstruction. So is soft tissue getting in the way? Does the patient have sleep apnea? Do we need to provide a chin lift or a jaw thrust? Going further down the respiratory tract, are they having a laryngospasm from light anesthesia, from secretions or some gastric contents that may have gotten down onto the cords and caused laryngospasm? Or have they frankly aspirated and are now in respiratory distress and hypoxic from vomiting and that gastric contents going down into the lungs? But if we do have an endotracheal tube, then obviously obstruction and laryngospasm are taken out of the picture, but we still could have some issues. Did the tube migrate? Did it main stem into either the right or the left main stem bronchus? So we're only oxygenating and ventilating one lung. Do we have a pneumothorax? From our side, did we provide too much pressure, which caused a rupture of a bleb or a pneumothorax? Or from the surgeon's side, did they get near the diaphragm and for whatever reason cause a pneumothorax? Could the patient have a pulmonary embolism during surgery? It's not common, but with certain malignancies or if a patient has a history of DVT or PE, it's certainly possible. Does the patient have a mucus plug that we need to clear through the endotracheal tube? Do they have pulmonary edema from excess fluids or failing heart? Do they have bronchospasm from COPD or reactive airway disease or asthma? Or simply, do they have atelectasis and do we need to provide more PEEP or do we need to open their lungs with some ventilation strategies? Last I mentioned negative pressure pulmonary edema, and this is not common, but we do see it sometimes in young patients. And it's basically when a patient is breathing spontaneously and they actually have an obstructed endotracheal tube, like from biting down on a tube, or maybe they're breathing spontaneously with a supraglottic airway or spontaneously with a nasal cannula or a mask, and they try to breathe against a closed glottis like laryngospasm. So if you can imagine, if they bite down on the tube and their diaphragm contracts and creates a negative intrathoracic pressure and air can't follow that negative intrathoracic pressure because the tube is obstructed, then interstitial fluid actually gets pulled into the lungs and into the thorax, and it can cause some pretty significant pulmonary edema and hypoxia to the point where the patient might be in distress and might need to remain intubated. And we typically treat that with some diuretics and some time. Moving on to another complication, post-op nausea and vomiting, or PONV. Actually, patients sometimes say that this could be worse than pain. So they'd rather be in pain than have post-op nausea and vomiting, which is interesting. Some of the risk factors we see for post-op nausea and vomiting, females that are of a younger age, obviously if they have a history of post-op nausea and vomiting and prior surgeries, or if they have a history of motion sickness like cars or different amusement park rides. Being a non-smoker puts you at risk, so one of the only things that smoking is beneficial for. The procedure that's being done can put them at risk, so if it's an abdominal procedure or a gynecological procedure, they're at higher risk. And then the type of anesthetic we use can put them at a higher risk, volatile agents and nitrous oxide and opioids being the main players there. So what can we do? We can start off by putting a scopolamine patch on the patient. I like to do this either the night before if you see them in a preoperative clinic or the morning of the procedure so that the transdermal patch can start working. We can give them preoperative promethazine or Phenergan by mouth, and that'll help with post-op nausea and vomiting. If the patient tells me that they've really had trouble in the past and maybe they've gotten admitted for post-op nausea and vomiting, then I will avoid volatile agents entirely and provide a TIVA or a total IV anesthetic with a propofol infusion, and that typically seems to work. We also give dexamethasone soon after induction and ondansetron near emergence to prevent nausea and vomiting. And then in the post-op area, if they need rescue medications, we can still give another dose of ondansetron, metoclopramide, or prochlorperazine for rescue medications. An obvious complication that we see is pain. With the opioid epidemic, we're seeing a lot of changes in the way we treat pain, but there are some teachings. One of them being the wind-up phenomenon, and this may be hard to understand, but I'll give it a shot. And it's when a patient has repetitive painful impulses, the spinal neurons become used to it or excitable, and this results in something called central sensitization and can lead to chronic intractable pain. So, research has sometimes shown that if you provide preemptive analgesics, so in the form of gabapentinoids or NSAIDs or acetaminophen or regional neuraxial blocks, prior to the patient feeling that pain under anesthesia and prior to their spinal neurons becoming excited, then you may be able to reduce the risk of chronic intractable pain in the future. With that said, we are moving towards providing opioid-free anesthesia, or as opioid-free as possible. So we may not want to treat that preemptive analgesia with opioids. We see that there is some opioid tolerance, and research has shown this. We've seen in the past patients given opioids for the induction of anesthesia and maintenance of anesthesia. Sometimes the patient becomes tachycardic, hypertensive, even though the depth of anesthesia is sufficient. And so their sympathetic activity is reactive. And we'll treat that with opioids while the patient is asleep under anesthesia. And some research actually has shown that when we do this, the patient might be having some tolerance. So then when they wake up from anesthesia and require opioids in the post-op area, they don't react as well to the opioids and then actually need more opioids. So we think that if their first exposure to the opioid is after emergence, it may be beneficial to the patient. To try to avoid the use of opioids, we'll give different medications while the patient's under anesthesia. Beta blockers can blunt the sympathetic activity, and so the patient wouldn't be hypertensive and tachycardic. Lidocaine infusions have come into favor, and they also can reduce the need for opioids. Same with a ketamine, either bolus or infusion throughout the procedure, and a magnesium bolus throughout the procedure. All of these things together will help us avoid the use of opioids while the patient is asleep, so that their first exposure to opioids will be on or after emergence, and we would have to use less opioids in the post-op period to keep the patient's pain controlled. So talking about emergence, this is really kind of the end of the case or the landing. We obviously turn off the anesthetic agent, whether that be the inhaled anesthetic or the IV anesthetic. At this time, if the patient is paralyzed, we would go ahead and reverse the paralytic. Now, historically, we haven't had Sugaminex, so we've used a combination of neostigmine and glycopyrrolate to increase the amount of acetylcholine at the neuromuscular junction. But in order to do so, the paralytic would have had to wear off somewhat, and the patient would have to have twitches. If you reverse early, when the patient is still paralyzed with neostigmine and glycopyrrolate, you actually see a reverse effect, and the patient has some prolonged paralysis. And if you've ever seen a patient wake up being weak, it isn't a pretty thing. So we try to avoid this. Thankfully, we've gotten Sugaminex, which means that at any point during the anesthetic, whether the patient just received paralytics or they've received them 30 minutes ago, an hour ago, It doesn't matter. We can give a dose of Sugammadex and pretty much have immediate reversal. So for those surgeons that historically like paralysis for closing or for whatever reason, and historically we've on our side tried to fight giving more paralytics because we're worried about the patient being weak on emergence and extubation. We can now feel free to give additional paralytics and then use Sugammadex to reverse that very quickly at the end of the case. The only issues that we have with Sugammadex, cost can sometimes be an issue. And then we are seeing some side effects, some bradycardia or allergic reactions, or even cardiac arrest, which has been described with Sugammadex. And then once the anesthetic's off and we reverse the paralytics, we just follow our basic extubation criteria, which is an adequate oxygenation, adequate ventilation, adequate tidal volume with a normal respiratory rate. The patient should be protecting their airway and strong, and then we go ahead and extubate. Last, we talk about disposition, and this is really determined by what facility or hospital that you practice at, whether or not certain patients can go to the PACU and the regular nursing floor versus needing a higher level of care in the ICU. But some of the things that I typically see need ICU, ongoing hypotension and requiring pressors, if they're hypoxic and need prolonged ventilation and intubation, if their disease process is worsening, like sepsis, if they're under-resuscitated or they're in need of close monitoring, I'll typically err on the side of ICU. But if a patient is just slow to emerge and they need a little time for the anesthetic to wear off, and they need a breathing tube for another hour or two, I think it's fine to bring the patient to the post-op care unit, to the PACU, with the breathing tube and a ventilator, allow the patient to wake up and extubate them in the PACU and send them off to the regular nursing floor just like any other patient. But obviously this is something that we discuss with our surgeons and we're on the same team about, and we try to do what's best for the patient.